Honorable Chairperson of this session, Professor Muhammad Bilal Alam, President, Bangladesh Society of Medicine, here present, Professor Ahmedul Kabir, Secretary General, Bangladesh Society of Medicine. We are honored here with us, Professor ABM Abdullah, Honorable my teacher, other teachers in front of me, Professor Fazlul Karim sir, Madam, Kanis Madam, Professor Khan Abul Kalam Azad, Professor Mujibur Rahman, and many other senior teachers, my colleagues. Assalamu alaikum. It's my great pleasure to be here in front of you regarding speech on newer drugs in the management of hypertension. You all know this is my working place at this moment, TMSS Medical College and Rafatullah Community Hospital, Bogura. You all know hypertension is an ancient topic, and first it is discovered near about 3000 before the birth of Christ, and it is written in the Yellow Emperor of China's book, and at that time it is called heart pulse disease. Till now, there are many drugs in the management of hypertension. In the earlier time, it is said that to achieve target blood pressure is most important. What kinds of drug, it is not important, but important is achieve target blood pressure. But nowadays, it is said there are many newer drugs which not only help in achieving target but also prevents hypertension mediated organ damage. The conventional drugs mostly not preventing target organ damage. There are some introductory speech on hypertension. It's a major risk factor of cardiovascular morbidity and mortality. It is incurable condition but mostly preventable. It is very easy to diagnose, simple to treat, but frequently remains undiagnosed and undertreated. It is mostly asymptomatic, and in 2009, WHO declared as silent killer. It is directly or indirectly responsible for 10 to 20% of all death. And cardiovascular disease risk doubles for every 20 millimeter of mercury in systolic blood pressure rise and 10 millimeter increase in diastolic blood pressure. Regarding treatment, pharmacological aspect is mostly neglected by the patient. It is very important, not only by that is non-medical person patient, but also patient, those are medical person, they also does not consider non-pharmacological treatment part of treatment as a part of treatment. And adherence to lifelong treatment is very poor. Proper counseling significantly improves compliance to treatment. Treatment regarding hypertension associated with 35 to 40% reduction in incidence of stroke, 20 to 25% reduction of incidence of MI, and more than 50% reduction in incidence of heart failure. Now come to the definition you all know. Defined as the level of blood pressure at which benefits of treatment outweigh the treatment cost and side effect of the drug therapy. And conventionally, it may be defined as persistent rise of blood pressure above normal range. Regarding prevalence, global prevalence in 2015, that is 1.13 billion, that is 113 কোটি লোক hypertension suffer করছে. The overall prevalence of hypertension in adult population in around 30 to 45%, and prevalence above 60 years of age is around 60%. Regarding classification, so regarding prevalence, there are two publications. One is NCD Risk Factor Survey done by Bangladesh Society of Medicine 2010, and uh, the team leader of this research team leader is Professor Mujibur Rahman, and they published prevalence is 17.9%. Prevalence 17.9%. Another study, epidemiology of hypertension among Bangladeshi adults, published in Journal of Human Hypertension. By following JNC7, it is 17.9%, and by following SCC AHA guideline classification, it is 40.7%. So just double or more than double. So regarding classification of hypertension, there is ambiguity. There are lots of body internationally. Each and every one are highly authorized. JNC7 2003 classification, I think, most accepted in our country. But another classification, ACC and AHA 2017, depending on spring study. Here, the elevated blood pressure, that is 123/29 and less than 80, that is called prehypertension in JNC7, and in JNC7 130/39 also called prehypertension, but in this classification it is called stage 1 and stage 2, that is in JNC stage 1 is considered as stage 2 in ACC and AHA. ESC and EAC's classification অনেকটা like that of JNC7 classification, that is stage 1, grade 1, grade 2. So among this ambiguity, in 2020 to 2020, ISA's International Society of Hypertension gives a classification. I think it is compromising. JNC and ACC have ঠিক মাঝামাঝি একটা presentation, that is normal less than 130, systolic, diastolic less than 85, high normal 130, 139, and or 85 to 89. Then grade 1 and grade 2, just like that of stage 1 and stage 2 of JNC7 classification. So if we follow this classification, এটা অনেকটা আমি বলবো যে একটা compromise classification of JNC and ACC and AHA. Now regarding history of classification, high blood pressure একটা disorder first recognized by Richard Bright in the year Richard Bright. It's a disorder. It is first recognized by Richard Bright. Again, English clergyman Stephen Hale invented manometer and first published measurement of arterial blood pressure in a horse in the year 1733. Clinical blood pressure measurement first by Italian physician Rivarossi in the year 1896, and he invented curve-based mercury sphygmomanometer. And in 1905, Korotkov, Russian physician, discovered Korotkov sound. Regarding treatment, from ancient time, when it was called heart pulse disease in China, they adopt loss of blood by acupuncture, venesection, and bleeding by lysis. These are the old technique of treatment of hypertension. Now, invention of antihypertensive drug, you all know. First, in 1940, peripheral sympathodiuretic, ganglion blocker, etc. are discovered. In the year 1950, direct vasodilator. In the year 1957, thiazides. Then subsequently all other drugs up to 1990. Now, how we will diagnose hypertension? Diagnosis should not be made on single office visit, usually 2 to 3 visits at 1 to 4 week interval. The diagnosis might be made on a single visit if blood pressure is more than 180/110, along with hypertension mediated organ damage if present. Regarding treatment, after establishment of hypertension, whether it is stage 1 or stage 2 or grade 2 or grade 3, if it is 140 to 159 oblique 90 to 99 along with along without target organ damage, then follow up. Follow up non-pharmacological management, and we wait up to 6 months. If not controlled, then add antihypertensive drugs. But if there is 160 or more than 160 oblique 100 along with organ damage or without organ damage, according to ICS 2020, we should start antihypertensive drug. Now, non-pharmacological treatment, which is very important in managing chronic illness like hypertension as well as other diseases like diabetes mellitus. But our patients does not consider it as treatment. Still, it is very important, and it includes salt restriction, healthy diet, moderation of alcohol consumption, weight reduction, smoking cessation, exercise at reduced stress, and induce mindfulness. Now, regarding classification of antihypertensive drug, you all know diuretics, renin-angiotensin system inhibitors, calcium channel blockers, beta blockers, alpha blockers, central sympatholytic. Though these drugs are less used, particularly methyl dopa, still used in pregnancy. Sympathetic nerve terminal blockers, reserpine and guanethidine, and direct vasolators, hydralazine, nitroglycerin, etc. nitroprusside. So these are 8 groups of antihypertensive drug used in our country or all, in fact, in the whole world. Regarding treatment, step 1, AC inhibitor or ARB plus calcium channel blocker in low doses. Step 2, A plus C in high doses, full doses. Step 3, A plus C plus diuretics. And step 4, add spironolactone. এবং beta blocker, consider it in any step if patient having angina, post-MI, heart failure or atrial fibrillation, or young women with or planning pregnancy. In that case, beta blocker is important. Now, newer drugs. In fact, in the management of hypertension, newer drugs খুব অ্যাভেলেবল না। আমরা ঠিক আগের ড্রাগেরই কিছু নেক্সট জেনারেশন, কিছুটা কেমিক্যাল কিছুটা কেমিক্যাল চেঞ্জ করে কিছুটা নতুন ড্রাগ, কিন্তু একবারে নিউ অরিজিন কোনো ড্রাগ নট ইট অ্যাভেলেবল। দিস ইনক্লুডস এসি ইনহিবিটরের ভিতরে পেরেন্ডাপিল, এআরবির ভিতরে টেলমিসার্টেন, ইন দ্য ক্যালসিয়াম চ্যানেল ব্লকার সিনলিডিপিন, লেব অ্যামলোডিপিন, thiazide, indapamide and chlorothiazide, loop diuretics torsemide, and beta blockers in ভিতরে nebivolol. These are relatively newer antihypertensive agents. In ARB, telmisartan is most important. It gives 24-hour coverage and equally effective. Like that of other olmesartan, it has 2 extra advantages: lowers cholesterol level and improves insulin sensitivity. And it is most important, patient having hypertension with diabetes, the drug of choice is telmisartan in managing hypertension because it reduces blood sugar 20% and reduction of new onset diabetes mellitus around 16%. Azilsartan is another next 8th ARB. It is also like that of telmisartan. Regarding amlodipine, it is calcium channel blocker, and it is the first line treatment option to treat hypertension. And FDA approved it in the year 1996 after it has been a good choice of drugs for physician to treat blood pressure, high blood pressure. But the most important side effect of amlodipine is it causes edema or fluid retention in around 41%. And it is very much alarming to our patient. So each and every physician should motivate the patient before prescribing amlodipine যে এরকম একটা ড্রাগ, এটা একটু পানি আসতেই পারে, এটা ভয়ের কোনো কারণ নাই, নইলে পেশেন্ট বেশিরভাগ পেশেন্ট প্রচণ্ড ভয় পায়। Another that is cilnidipine. It is less potent than amlodipine. 5 milligram amlodipine is equivalent to 10 or more than 10 milligram cilnidipine. It causes less pedal edema. Another important drug, lev-amlodipine, is highly potent, and 2.5 milligram, 5 milligram of amlodipine is equivalent to, regarding potency, 2.5 milligram lev-amlodipine. And less chance of edema, that is edema causing only in 2% cases. These are also calcium channel blocker, relatively newer, but not so popularized to the physician. Indemamide and chlorthalidone, diuretics, thiazide diuretics, their potency a bit higher than thiazide diuretics, regarding development of side effect like that of thiazide diuretics. Current evidence suggests that initiating treatment of hypertension with beta blockers leads to modest cardiovascular reduction and little or no effect on mortality. These beta blockers effect are inferior to those of other antihypertensive drugs like AC inhibitor ARB, calcium channel blocker, and diuretics. So these three groups, that is AC, ARB, calcium channel blocker, among diuretics regarding prevention of target organ damage are more important than beta blockers. But however, newer generation of beta blocker are important in the management of hypertension with heart failure, hypertension with angina, and hypertension with myocardial infarction. Bisoprolol and nebivolol, though it is beta blocker, but they are very important, particularly in patients with asthma. Nebivolol releases nitric oxide and thus, in contrast to other beta blocker, can improve libido. Now, novel therapeutics in hypertension. These groups of drugs are at the clinical or clinical trial level, still not at market, but in future, these will be available probably in the market. These groups of drugs has many advantages. Among the first, A2 angiotensin 2 agonist. A2 agonist receptor stimulation demonstrate a significant effect on tissue repair, cell differentiation, and promotes diuresis and natriuresis. Moreover, it has proven beneficial to the brain, to the lung, heart, blood vessel, kidney, pancreas, and skin. Another drug, ACE2, angiotensin 1 to 7. These also have much beneficial effect, particularly in preventing or slowing the target organ damage. Another drug, natriuretic peptides, lead to vasodilation, natriuresis, diuretic effect, and also protect against podocytic injury. NPS interact with membrane-bound particulate guanylyl cyclase. Another drug, non-steroidal mineralocorticoid receptor agonist, and it is superior to spironolactone, that is steroid mineralocorticoid receptor agonist. Aminopeptidase A inhibitors is also important, and it is in phase 2 or 3 trial. So these newer novel antihypertensive drug, those who are at this stage at clinical trial, that is preclinical or clinical phase 1, 2 or 3 trial, those 8 not marketing, that is not in phase 4 clinical trial, near future or in future probably these will be available in treating hypertension. They have better efficacy, less side effect, and better ability to prevent end organ damage. So we are waiting for these groups of drugs to treat patient with hypertension in preventing or in slowing the development of target organ damage. So take home message, hypertension is a significant risk factor for occurrence of stroke, cardiovascular and renal diseases. Initiation of early treatment and optimum control of blood pressure limits the progression of target organ damage significantly. Several antihypertensive drugs are commercially available that help maintain blood pressure, improve the quality of life of patients with hypertension. However, these drugs, even though they are effective in controlling hypertension, have limited ability to prevent end organ damage. Several novel peptides, non-peptides, drugs have been shown better efficacy and safety in clinical trials than existing drugs. In future, peptide-based strategies may prove a better option due to lack of adverse side effect and the prevention of end organ damage. In this year, the slogan of WHO regarding hypertension, measure your blood pressure accurately, control it, and live longer. This is the picture of Hypertension and Research Center Rangpur. Till 31st May 2022, total number of registered patients in hypertension desk 28,000, in diabetic desk which we started few months back 693. That means near about 20, approximately 29,000 registered patients in this center. Among them, around 1,000 patients we lost them. Around 1,000 patients we lost them forever, and we are maintaining a data. Those registered died by telephonic contact or physical ভিজিটের মাধ্যমে আমরা আইডেন্টিফাই করি কারা আমাদের পেশেন্ট রেজিস্টার করার পরে মারা গেছেন। এরকম প্রায় 1,000 পেশেন্ট আমাদের মারা গেছেন। এখন আমাদের প্রায় 28,000 বা 27,000-এর মতো পেশেন্ট আমাদের সেন্টারে রেগুলারলি এবং কিছু কিছু ইরেগুলারলি আমাদের চিকিৎসা সেবা নিয়ে যাচ্ছেন। I, on behalf of Hypertension and Research Center Rangpur, expecting your cooperation for this center. Thank you all.